Hi everyone, my name is Basant Chana. I'm going to do a presentation on sepsis and septic shock. It's going to be a little bit more interactive, so it's going to need some input from you guys. Who here has worked with a patient who's had sepsis or septic shock? Put your hands up high. So most physios have, and some of the students have. And the reason why I am going to be doing this presentation is because, especially in the hospital setting, you do come across patients who have sepsis or are under septic shock, or they might not be diagnosed yet, but you as a physio, you might be the first person who are there, and we're going to talk about signs and symptoms that you can pick up, and you might pick up those signs and say, hey, this person needs treatment, and they need treatment urgently because it's a very serious condition, and if not treated, it can lead to death. So it's pretty serious. So we'll go back in time a little bit. In 1991, that was when the first official definition of sepsis and all the terms came into play. And there were 4 different terms, and they continued to 2001. SIRS, sepsis, severe sepsis, septic shock. But recently, with the newest guidelines, so another reason why I'm doing this is because the newest guidelines are new, and not everyone knows about the new guidelines. The definitions of sepsis and septic shock have changed, which changes which patients have them or which patients don't, and some definitions have been cut out as well. We don't really, with the new definitions, we're not really using SIRS anymore, or severe sepsis. What was previously severe sepsis is now just sepsis. Septic shock is slightly different, but still septic shock. SIRS, on the other hand, is not necessarily a bad thing. Before it was used, you could use it to define sepsis, but SIRS is, for example, a temperature of 38, 36, heart rate of 90. If you go for a jog, you have SIRS. Right, and you don't necessarily need an infection as well. So previously, you just needed 2 out of 3 to have SIRS. It doesn't necessarily have to be an infection, and it will be a good thing as well. SIRS can help protect you. So if you're losing blood loss, the way the sympathetic system reacts is to protect you. So it's not necessarily a bad thing. Sepsis, however, don't worry about that. Sepsis, however, is definitely a bad thing. So with sepsis is a life-threatening organ dysfunction caused by a dysregulation of host response to an infection. So basically what that means is when the body's response to infection injures its own tissues, and so it can lead to organ failure and eventually death as well. And so instead of SIRS, how can you figure out whether a person has sepsis? So we'll go back here. We have the Q-SOFA score. So Q-SOFA is just a score. You look at these 3 different variables at the person's bedside. It's really good for wards, good for HDU, not necessarily for the ICU. For the ICU, you'd go straight to the SOFA score. So, what are the variables you look at? Is the person's respiratory rate greater than or equal to 22? Is their blood pressure, systolic blood pressure, less than or equal to 100? Or do they have an altered mental state? And if so, if they have any 2 of these, they're on the line of going to sepsis, and will need it to be treated accordingly. Here is a more complicated score. I don't think you need to worry about it. I'm just going to show you what it looks like. It's hard to see anyways, but they look at different variables. So they look at liver, if it's working perfectly fine, if the central nervous system, platelet levels, the kidney function, and they'll put a score to see how likely they have sepsis. So now septic shock is a lot worse. So it's a subset of sepsis, but it's a lot worse. So septic shock is when there is where the changes are so profound that the risk of death goes up quite a lot. And so the way to identify whether the person has septic shock is basically they need vasopressors to keep a mean arterial pressure of greater than or equal to 65, and a serum lactate is higher than 2. So with this criteria, the mortality rate goes up a lot higher, to 40%. So it might sound a bit confusing. It's like SOFA, what do we do? So here's a nice template that goes over what you can do to identify whether a person is undergoing sepsis. So the first thing you will see is, does this person have a suspected infection? So things to look for infection, high temperature, whether they're on antibiotics. The funny thing about infection is you can only really do it retrospectively. You have to do the biopsy, you get you do the analysis, and then you find out whether the person has an infection. So the medical officers, what they'll do is, if they suspect this person has an infection, they'll put them straight on antibiotics. So the person has a suspected infection, you can do the QSOFA, and if they don't, if it's less than 2, if you still suspect sepsis, you continue with that path. Otherwise, you just treat as if a normal infection. If they have sepsis, then you can do this. The medical officers will generally do the SOFA score, decide they have sepsis, determine if it's septic shock, and then treat accordingly. Those are the variables over there, just what I showed previously. Regarding mortality rate, why is it important to know about sepsis? And well, this is why. 10% is a mortality rate for sepsis. So 1 in 10 people will die just for having sepsis, and a person who has septic shock has a 42% of dying, and that's pretty serious. Yeah, that's pretty serious. I'll go over treatment plan later, but basically what they say with the treatment is that if for every hour that you don't treat for septic shock, for example, the rate of mortality increases by 7.8%. So every hour wasted is going to increase the likelihood that the person's going to die. So the sooner you catch it, the better it is. All right. So, well, epidemiology. The incident is 1.1% roughly, based on the 2005 paper. Every new cases in Australia is about 15,000 new cases, 16,000 new cases, and each case will cost almost $40,000. The 3,000 patients will die from sepsis. That's what I meant to write. And it causes more deaths than breast cancer, prostate cancer, colorectal cancer. And so it's pretty important. And in the USA, it's a cause contribution of almost half the deaths in the USA. So it needs to get treated, and it needs to get treated ASAP. And how can it get treated? Well, here are some options. Probiotics, antibiotics, in this case antibiotics, is the first line of treatment. So antibiotics, the appropriate ones to deal with it, vasopressors, ventilation if they have a difficulty, if it goes so serious they have difficulty with ventilation, fluids, corticosteroids, and surgery. Surgery will probably be for if they have to remove the tissue. It's so infected they just have to remove the tissue. Yeah, so the average decrease in survival goes down by 7.6% if a person has septic shock and they're not being treated. So it's pretty serious. So as a physiotherapist, what can you do? Well, like I said earlier, is being able to identify and knowing when to refer. Medical officer, you're gonna have to take a look at this patient, sir. Managing if the reason of the infection that the person has is pneumonia related, and if it's producing sputum, we will use chest physio to manage that. So that's the role of the physio. But the infection can be anywhere. So the infection might not necessarily be something the physio will have to deal with. And lastly, just monitoring signs throughout the treatment. Is their blood pressure dropping below 100 millimeters of mercury and whatnot. So in summary, sepsis, the definitions have changed. SIRS and severe sepsis is removed, if you've learned that before, and now sepsis and septic shock, and they're very serious. If they're not treated, the rate of survival goes down quite a bit every hour for the first 6 hours, and it's important to keep an eye on the monitor when you're working on treating a patient who has sepsis. So that is my presentation. References.